Hello. Thank you very much for the introduction. So this is not as much obviously a factual talk and giving a little bit of perspective on where I think we are with respect to handle resistance for checkpoint inhibitors. I would think that all of us can agree that this is a particularly challenging area. Here you see my disclosures. So we'll talk a little bit about both clinical questions as well as mechanistic questions. So in terms of the clinical questions, the questions I think are important to address are one, what's appropriate clinically to do in a patient who starts with single agent PD-1 or PD-L1 inhibition with or without a CTLA-4 inhibitor? So somebody who got single agent therapy or immunotherapy alone. And an additional question that I think is going to be important for us to assess in this is, do we view that differently if that patient had experienced clinical benefit versus if that patient had not experienced clinical benefit? Then we'll spend a little bit of time clinically discussing what is the appropriate thing to do in patients who have received chemotherapy plus immune checkpoint inhibition. And that you will see is even a less advanced field, in part because the approval of combinations, including chemotherapy and immunotherapy, were approved after immunotherapy alone approaches. And so we have even less data in that setting. And again, I think it's important to evaluate, does this differ among patients who have experienced clinical benefit versus not experiencing clinical benefit? We'll also address a few mechanistic questions. I think that it's hard to go in depth into all the mechanistic questions in a 15-minute talk. But of course, there are some tumors that are primarily refractory to immunotherapy. And in those cases, what do? There are some tumors that are initially responsive to immunotherapy, but then subsequently become unresponsive. And how do we deal with that? And I think last, the question is, are there tumors that are sort of not truly refractory to immunotherapy, but we just haven't quite figured out how to address those tumors yet through appropriate combinations? And I know that Dr. Agarwal's talk later in the session will address some of those issues. So first, what's the appropriate thing to do in patients who have received single agent PD-1 or PD-L1 inhibition with or without a CTLA-4 inhibition? And I think that that the first practical question that we get is, if patients have not received a CTLA-4 inhibitor, should that be added to their therapy? On a practical level, that may be something you can do. Obviously, at this point, at least for patients who have PD-L1 expression in at least 1% of their tumor, there is approval for combinations of ipilimumab and nivolumab, but I'm not really aware of data looking at that combination in a salvage setting. And I will say that one thing that always irritates me when I'm on the inpatient clinical oncology service is when a practitioner will ask us to just add a CTLA-4 inhibitor to a PD-1 inhibitor to give patients just a stronger immunotherapy. And obviously, that's not really the way to look at immunotherapies. It's more mechanistically, are you in fact enhancing the outcome? So I'm not aware of a lot of data of ipilimumab and nivolumab in a salvage setting. This is data that I was involved with in a study where we looked at a different PD-1 inhibitor, in this case actually a PD-L1 inhibitor, durvalumab plus tremelimumab. And we looked at the response that would be seen in a checkpoint inhibitor experienced patient if they received the combination of these two agents. And the response rate was 5%. You can see the breakdown here, which is based on PD-L1 expression at baseline. And the progression-free survival data also was not particularly impressive. So 5% response rate that didn't appear to differ whether the patient had previously obtained clinical benefit with a PD-1 or PD-L1 inhibitor versus had they not received benefit. So at least my bias in that setting is that until we have data that adding a CTLA-4 inhibitor in the salvage setting is beneficial, I would not take a patient who received a single agent PD-1 or PD-L1 inhibitor and just add a CTLA-4 inhibitor. Another question that we see addressed frequently is, should they continue their assigned immunotherapy? And I think that may be a little bit more of a complex question. I think that one thing that we all do in our clinical program is deal with oligoprogression. We have many patients still alive and doing well from the Keynote 001 study. I will say many of those patients received treatment to at least one lesion after they obtained disease nadir. This is a small study by Scott Gettinger looking at treating oligometastatic disease, and many of them, in fact, did quite well. And I think that we all are starting to develop some anecdotal data that would support this approach in patients who do have progression of disease, but progression that is restricted to a limited number of sites. Now, if we take aside the patients who just perhaps have oligoprogression and maybe receive treatment to one site, the FDA has looked into the likelihood of response to PD-1 inhibition in a patient who continues along with a PD-1 inhibitor after they have had radiographic progression. And in their analysis, what they show is maybe about 8% of patients who continue on a PD-1 inhibitor, in this case it's nivolumab, after progression on that PD-1 inhibitor do subsequently have a response. And we now have similar data that was presented by David Gandera at ASCO for atezolizumab. And so although this is a treatment strategy, in my case, in my way of thinking, this is one that makes me very nervous. So in here, there is a minority of patients who are treated beyond progression. And if you only look at the patients who are treated beyond progression, you'll see that the response rate is 8%. But this is 10 patients out of 121 patients who continued beyond progression. Another way of looking at this is that of 535 initial patients, 10 of them eventually had a response after treatment. That, of course, is getting you into the range of under 2%. And so what I would say is that in a carefully selected patient population who appear to be deriving benefit, there may be a high single-digit rate of response to immunotherapy. But this is only in the patients in whom the physician thought they were continuing to derive potentially some benefit and wanted to continue them on therapy. And I don't know that this is a particularly effective approach across the spectrum of patients. In terms of the Checkmate 153 study, to me, this is actually an underappreciated study, and this is evaluating a different question. The first question is, what about patients who, when I talked about oligoprogression, who maybe just have a single site of disease or maybe a small number of sites? The second question was about patients who were felt to be deriving benefit, even though the radiographic scans were not showing it. And this is a different group of patients. These are patients who are deriving benefit. And the question here, which does get at sort of resistance in a different way, is it better to continue nivolumab, which is the PD-1 inhibitor evaluated here, versus have a planned stop at a year? And to me, this is actually a very underappreciated data set. As full disclosure, I was part of this effort. But nonetheless, there are many efforts I'm part of, and this is one that I think has maybe gotten less attention than I think is appropriate. This was a little bit more than an expanded access program, but as part of this study, there was a randomization of patients who were benefiting after a year of nivolumab to either continuation of the nivolumab versus continuing beyond a year. And what you see, and I'll show you in the progression-free survival data here, is that the progression-free survival was strongly in favor of continuing the nivolumab. You can see the hazard ratio here is less than 0.5. One thing that I don't capture here, but also leads me to some concern, is that in fact, it was not at all convincing that you just recaptured patients who had done well previously by giving them nivolumab subsequently. Here you can see that this was true among patients who had a complete or partial response, shown over on the left, as well as patients who had stable disease, shown on the right. So for both of these groups of patients, there were substantial benefits that were seen with a hazard ratio less than 0.5 in terms of progression-free survival. And again, this data has recently been updated. I don't think it has been in a printed version yet of JCO, but it is available online. And in terms of overall survival, you could see at this point there was a trend in favor of increased survival in patients who continued beyond a year versus patients who stopped it at a year. But what I would additionally add is that in the update from the Journal of Clinical Oncology, in an intent to treat analysis, the p-value was actually less than 0.5 for the intent to treat population, indicating a greater survival. This is again from a presentation and abstract, but the updated data shows a p-value less than 0.05 for continuing beyond a year. Now, just as an aside, many programs, including the pembrolizumab program, have stopped at 2 years, and some would say, well, if the solution is, that 1 year isn't enough, why don't you go till 2 years? My personal bias is that is not the sort of most rational extrapolation of the data from the Checkmate 153 study. So now, although we all know that there are potential clinical trials, are any of them so promising that we should pursue trying to get those drugs or drugs like them off protocol? And Dr. Agarwal will probably weigh in a little bit on this during her talk later on, but at least to date, I would argue that the answer is no. There's certainly nothing that I tell patients, oh, even though we don't have the data, you should be trying this. Obviously, we always discourage that. We would rather evaluate things in a rigorous clinical trial. But even on a theoretical sort of, would a relative, would you say, oh, they should get this combination afterwards? The answer to date, I would say, is there's nothing so suggestive of benefit that I would do that. So here's another real difficult clinical question. So if we decide to go to frontline chemotherapy, should we add immunotherapy to the checkpoint? I miswrote this. Should we add immune checkpoint inhibition to the frontline chemotherapy? And here I would say we have very little data to guide us. In general, in cancer therapy, if a patient progresses on their therapy, to continue that therapy has not been felt to be something that makes a lot of sense. My own personal bias is that it probably doesn't make sense to continue a PD-1 or PD-L1 inhibitor along with chemotherapy. But I would say this leads to very difficult questions in the clinic. Patients are sort of, maybe appropriately, really excited about this idea of immunotherapy, about the idea that they could achieve a long-lasting benefit with their immunotherapy. And as a result of that, patients really do want to often continue the checkpoint inhibitor along with chemotherapy. Insurance often has not necessarily set up a barrier there. So this is one of those difficult situations where I recommend against continuing the immunotherapy in this setting along with chemotherapy. But on the other hand, patients often sort of push me into doing it. And I think the last question before we move on to other settings is, should we consider patients differentially based on whether they did or did not receive benefit with their immune checkpoint inhibitor? We will be able to address this a little bit in the mechanistic issues, but I would say that until we have effective therapies that combat resistance, it is not clear to me that we should be considering patients differently based on whether they did or did not initially receive benefit from their therapy. So what do we do in patients who responded or who received, chemotherapy plus immune checkpoint inhibition? And I think that the answers are really very similar. I wouldn't necessarily be adding a CTLA-4 inhibitor if they haven't received it to date. I just don't think we have any data in that setting. I don't know that I would be continuing the assigned immunotherapy if we change the chemotherapy. There's a little bit of data of immunotherapy in second-line therapy. There was data presented at World Lung back when people actually went to conferences, looking at pembrolizumab plus docetaxel. In this case, I'll show you the next slide. There actually was a benefit with respect to progression-free survival by adding pembrolizumab to docetaxel. But this was in patients who had not previously received a PD-1 or PD-L1 inhibitor. And so we really don't have a lot in the way of data for patients who have received, for instance, chemoimmunotherapy, should they receive chemotherapy plus immunotherapy subsequently. Again, I'm not aware of clinical trials that would convince me that this is what patients should get. I think it's certainly important to continue to refer patients for clinical trials that will evaluate those questions, but to date, I don't think we have an answer. And then again, I don't think without effective therapies that it makes sense to just necessarily be differentiating patients based on whether they did or did not receive benefit initially. So mechanistic questions, and I can't go into depth on this in a 15-minute talk, but I will go through a few data sets highlighting largely things that at my own institution at UCLA, largely in Tony Ribas's group. There are some patients who just are not set up for a benefit from immune checkpoint inhibitors. This is from Willie Hugo, again, part of Tony Ribas's group, and showing gene expression profiles that are consistent with lack of response to PD-1 inhibition. This, again, is just looking at some of these signatures, looking at heat maps that would predict a lack of benefit. Also, some patients just don't have either lymphocytes or lymphocytes in the right place. This is work from Paul Toomey when he was at UCLA and Tony Ribas's group. This is not specific to lung cancer, but looking at melanoma, in which patients in whom CD8 positive T cells were excluded from the area of the tumor were less likely to derive benefit than those who did have infiltrating lymphocytes in the site of the tumor. This is sort of an intriguing data set. We've started to see a lot of clinical data sets indicating that patients who are receiving antibiotics prior to going on an immune checkpoint inhibitor have a worse outcome. We all have some concerns about potential bias in these clinical data sets. But from this study, there actually was even some additional data where they did fecal microbiota transplantation from mice that had a response to immunotherapy into mice that did not. And in fact, there was a benefit for doing this, from basically transplanting the microbiome from a mouse that responded to a mouse that did not. Now, this still has not led me to leave my academic post to try and set up a stool banking program in industry, but nonetheless does lead to some intriguing data. One other data set, again, out of UCLA, Jesse Zaretsky is the lead author from Tony Ribas's group, looking at patients who initially responded and then subsequently had resistance. And what they showed was that JAK2, which is particularly important in an adaptive immune response, was mutated in some of these patients, and that this makes them particularly poor candidates for future immunotherapies that would be at directed against specific antigens in their tumor. And this again begs the question, you can make a strong argument why it would be better to a better patient population for salvage immunotherapy trials if they had a response to immunotherapy. But you could also make an argument that patients like this are now particularly poorly set up for a response if they develop secondary resistance to immune checkpoint inhibitors. And this just shows some data, I can't go through it in depth, about the resultant loss in interferon gamma signaling. So to conclude, this is a lot of information, admittedly, but unfortunately, the answer to most of our questions on clinical management is I don't know. We just don't have the data to guide us on good approaches in patients who develop resistance to immune checkpoint inhibitors. I think that until we have approaches that show clear benefit of immunotherapy-based treatment in a salvage setting, whether or not we should be considering patients differentially based on whether they did or did not have benefit from their prior immunotherapy regimen is completely unknown. And my personal bias is that until we understand what's causing resistance, we're going to have a particularly difficult time devising effective therapies to combat it. And in particular, I think that it is likely that different patients are going to have different mechanisms of both primary and secondary resistance to immune checkpoint inhibitors. And so I think that looking for this drug that's going to sort of salvage all immunotherapy failure patients seems to me to be a pretty long shot. And instead, what is a more likely effective approach is to be targeting specific populations who stand to derive particular benefit from specific approaches that would combat resistance to immunotherapy. Thank you.